Dawnson, longtime faculty member here at vascular surgery. Dave is, maybe some of you don't know this, Dave has just returned from a 3-month sort of advanced level fellowship at the Mayo Clinic to look at some new endovascular techniques for complex thoracic and aortic vascular disorders. So part of his talk is going to be highlighting sort of what he learned in the summer camp, that's sort of the deal here, but also a little bit about new techniques and what's an evolution for the endovascular management of complex aortic disease. Dave, thank you.
Thanks, Jerry. So that's what it is, advances in endovascular management of complex aortic disease. No financial disclosures, but I will be talking about some non-FDA approved therapies. So April, May, and June, I went across the country and went to the Mayo Clinic, went to the house that Will and Charlie built, and participated in their program for advanced aortic interventions. And that was a great opportunity to see really what's happening in the places that have access to technology that really most U.S. centers don't. Many of the things that are being done there are commonplace in Australia, Europe, South America, even Canada. And it's a chance to kind of get a window on what's coming down the pike in the U.S. I really want to thank Dr. Farmer for allowing me to do this, and my colleagues for picking up the slack during my absence. I worked with Gustavo Oderich, who's a vascular surgeon at Mayo Clinic, and he recently published a textbook, Endovascular Aortic Repair. And I would consider this a great reference if you're interested in the topic. Many of the illustrations from that book, illustrated by David Factor, are included in this talk with permission. So what I'm going to do is talk about really what's happened over the past 3 decades. I'm going to compress that into about 90 seconds. But provide an overview of the spectrum of aortic pathologies that are now treatable with endovascular techniques, talk about some of the challenges, and then talk about some of the things that are important to implement a new technology in the aortic therapy program. So with regards to the development, let's talk a little bit about the pioneers, the names, what happened with commercialization of technology and the continued development that addresses really some of the shortcomings of the early systems that were responsible for short and long-term failure modes, these devices, and some of the shortcomings that limited their applicability to patients based on their anatomy. There's innovations going on by medical device companies, but really you have to understand that for the most part it was physicians that drove this. It was surgeons and radiologists who invented these devices, worked on them in the lab, implanted them in people, and then worked with industry to develop the kind of technology that makes it quite easy to deliver in many cases. Well, for the people who sit in the back, who maybe don't do vascular surgery, first thing you have to understand, the most common aortic problem that we deal with is an abdominal aortic aneurysm. And the abdominal aortic aneurysm, where there's a focal dilatation of the aorta, there's a thinning of the aortic wall, and because of that, there's increased wall stress, and that creates a dangerous situation for the patient. Abdominal aortic aneurysm rupture is most commonly fatal, but it can be treated in many cases if there's contained rupture and the patient has rapid access to care. Now, when I was a resident, all abdominal aortic aneurysms were fixed with an open operation. When I was a fellow, I was at the Society for Vascular Surgery meeting in Anaheim, and this guy from South America talked about his experience with an initial implantation in humans of grafts that were delivered through the femoral artery, held in place with stents, fixing an abdominal aortic aneurysm. I knew that day that he was crazy and that wouldn't work. But his crude devices had a lot of shortcomings. They were associated with a really high failure rate. But what's happened since then is these simple devices that were manufactured by investigators have become commercialized. And by 1999, there were the first 2 grafts that were introduced to the U.S. market. And when that happened, every vascular surgeon in the United States said, crap, I'm not ready to treat what's really a core part of our profession, disease of the aorta. And so it was a turning point for vascular surgery that vascular surgeons needed to learn a whole new set of tools. It was not unlike what happened when people started plucking gallbladders out of abdomens through laparoscopes. A whole bunch of university professors said, well, that'll never work. And a whole bunch of people in the community said, I think it might. The development of complex EVAR, complex endovascular grafts, was really going on at the same time the clinical trials were bringing the first devices to the market in the U.S. And since that time, there really has been a continued development of the complex endografts. And two people in the U.S. are major players, or were. Roy Greenberg at Cleveland Clinic was the one that really developed many of the fenestrated endograft technologies that are used for treating the paravisceral and thoracic aortic segments. Roy sadly died a couple of years ago from what may have been a radiation-induced malignancy. Tim Chuda at UCSF was one of the people who pioneered the development of one of the modular endografts that we use frequently, but was the first to put a multi-branched thoraco-abdominal graft in place for thoraco-abdominal aortic aneurysm. Now, the current therapies available include a number of commercially available devices, and almost all of these are intended for treating the infrarenal segment. You land the graft below the renal arteries, you preserve flow of the renal arteries, and the evolution of these things is make it more reliable, more deliverable, get through smaller iliac arteries, shorter necks, and make them more durable. It is the established treatment, and most patients who have an abdominal aortic aneurysm are treated with an endovascular technique, the overwhelming majority. We know that this is safe, but it doesn't really expand the indications. We don't treat small aneurysms because that doesn't really have benefit. We wait till they're of a size that they have some risk to the patient. And we don't treat patients who are so ill or frail that the only reason to do the aneurysm repair is to get it done before they die. So if people are at the end of life, we often don't treat their aneurysm. Now, the thing that limits many of these, the durability of many of these, is the ability to get a seal. The graft has to go in the artery, expand outward, and just hold onto the wall. And there can be little hooks or barbs or something to hold it in place. But it requires a parallel wall of the aorta. And at the renal arteries, there's not a parallel wall. If there's a very short segment of parallel wall, if there is a bunch of clot or calcium at that level, if it's degenerated above that level, these are all situations where implanting the graft at that level is not durable, and we need some ways to deal with that. So some of the technology improvements focused on increasing proportion of aneurysms amenable to endovascular repair by dealing with these perhaps short or unfavorable necks. Make the devices easier to use. You can't idiot-proof them, but you can maybe make them idiot-resistant. Increase the safety and improve the outcomes, and avoid some of the later complications. Now, to do this, grafts have been modified. And so the modified grafts that are now being used have a variety of different customizations that can be done to create what we call scallops, fenestrations, or branches. And then they may have some additional modifications to help them be more deliverable and more usable. So this is an example of what a fenestration and a scallop might look like. Let's see. So a scallop is just a little cutout at the top, and this is something that might be included to accommodate a vessel at this level. A fenestration can be of various sizes, may be cut in the side of the graft to uncover a branch vessel. Now, there are, in addition to the customizable grafts, there are currently available some grafts that already have branches that are meant for the celiac, the superior mesenteric artery, and the renal arteries, and just off the shelf like this, but not available in the U.S. And some that are custom manufactured, where you give a prescription, so to speak, to the company for the length, the diameters, the location and sizes of fenestrations and branches, and have them custom manufacture a device tailored to the individual, a bespoke graft. The fenestrated graft, though, is now available on the U.S. market. And this allows us to at least have renal artery fenestrations and a scallop for the superior mesenteric artery. And this has allowed us to treat patients with disadvantaged aneurysms, necks. These are custom built. They come from Brisbane, Australia, so it takes a little while to order it, have it QC'd, have the plan delivered to the folks that make them, have the person cut out the little holes and sew in the little markers. And so by the time you send off the order, it may be 4 weeks before you're ready to do an operation. Now, with this in mind, there's a lot of innovation going on, but the U.S. is not where a lot of the innovation in medical devices occurred. The U.S. was the third country in the world to approve transcatheter aortic valve replacement, TAVR. And so if we look at what's happening with aortic devices, we're kind of in the same position. The FDA has a relatively rigorous approval process, and some of the things get down into very small details, like having to verify that there is an approved stent for the branch vessels, even though there's a non-approved stent that's being used for 5 or 10 years. But the FDA does provide the oversight that's necessary to establish safety and effectiveness. Now, because we don't have all of the types of grafts that we might want to have, there are physician modifications of existing endografts that can be done. And here are a couple of examples of cases where an endograft has been partially unloaded from the sheath that it comes in. Holes have been cut in it, and reinforcing rings and radiopaque markers have been sewn in place. The graft is reloaded and then implanted. Now, this has the advantage of being something that you could do without a 4-week wait. You could say, gosh, we really need this. Let's do this in the back table. And you could create this on your own. Most commercially available endografts can be modified. There's no standardized techniques. And the extent of this practice is really difficult to understand. I used to think it was relatively rare, but the more you go out and talk to people, the more you find it's happening in community hospitals. And so people who have this training are doing this frequently, but we really don't have an idea of how many because we don't collect data on that. The key to doing these physician-modified endografts, or PMEGs, is to have good planning, and we base this typically off CT scans that we reformat in 3D. We create a center line and then take cross-sections at right angles to that center line to be able to identify not only the size of the aorta, but where the branches are, where they are radially on a clock face, 360-degree circle of the circumference, and where they are up and down relative to each other. The case planning is really what's critical, because if you put the holes in the wrong position and you put the graft in, it's very difficult to get the catheter across the holes and into the branch vessels. And some people have started to do other things like create automated systems for this and make a template, a 3D printer generated template that can be used to help create these physician-modified endografts. Do they work? Well, yeah. There's actually a systematic review published last year that looked at 15 articles on physician-modified endografts. Most of these were done in the United States because of the lack of access to the other technology. Most were for patients who were symptomatic or had ruptures, contained ruptures, where they couldn't wait. And there's a pretty good technical success rate of 91%. The branch vessels, the renal arteries, the mesenteric arteries stay patent 97% of the time. Or you can get into them and they stay patent. So the results are actually pretty good for this, considering that these are for patients who are high risk and potentially in extremis. I'll give you an example of a recent case that I got to participate in. Of a 73-year-old, he had presented to the hospital with congestive heart failure, new onset, and had a very tight aortic stenosis, which was treated with an aortic valve replacement. But he was found to have a greater than 9-centimeter aneurysm of his aorta. If you look through the CT scan and scroll through the images, you can see that in the thoracic aorta, the aorta is pretty normal in size. But as soon as you get to the renal arteries, it starts to get real big. So there's no neck, there's no distance between the renal arteries and this really big aneurysm. And so this is someone who needs to have that seal zone extended above the renal arteries to get a good seal. But it's going to take time to manufacture something. So with a 9-centimeter aneurysm, it was felt that waiting around for this to either rupture or to get something from the manufacturer that might take an extended period of time was not in his best interest. So this is a case where a physician-modified endograft was done. A thoracic endograft, a tube was taken, and 4 fenestrations were put into it. You can actually preload guide wires through those so that you can get the catheter where it needs to be later to get into the branches. You can constrain it so that when you can partially deploy it into the aorta and then move it, rotate it, move it up and down to align the fenestrations with the branch vessels. And then when it's put in, because multiple vessels, branch vessels are being covered, spinal drain is used, evoked potential neuromonitoring is done. And this is all done through percutaneous access in the groin and a small incision for brachial or axillary artery access. And then once this is in place, you just do a branched graft that goes down into the iliac arteries. This is kind of what it looks like intraoperatively. The fenestrated endograft ends here, And you can see these markers are on the areas of fenestrations. And then inside that is a branch graft, and that's just being put in like a normal abdominal aortic aneurysm endograft. Once you have the thing in place, you can get through those branches. You can get catheters into the renal arteries, the branch arteries. You can put stents in there to secure it in place so it doesn't go up or down, and to give good seal. And then also stent the other visceral branches, the SMA. Intraoperatively, a flush aortogram shows patency. And the view, let's see if we can make that work. This view that looks like a CT scan is actually a cone beam CT. This is done with a rotation of the C-arm around the patient at the time of the operation to look at the branches, the stents, to make sure that they're well opposed. So you really do a CT scan using the imaging in the OR. Follow-up imaging, you can see here, he's got some fluid in the chest, but the endograft is in place. There's good stent to vessel wall apposition. There's complete sealing of the aneurysm. 2 branches go down to the iliac arteries, and overall, he's pretty happy with that. Gets to go home with no complications. When we're talking about these grafts and sealing higher, extending the seal zone above the level of the renal arteries, you might talk about grafts that go up to the level of the superior mesenteric artery, but below the celiac. But really what we want to do is get several centimeters of non-diseased aorta. And so if there is dilatation of the aorta above the renal arteries, this has to go higher. And if there's dilatation of the aorta at the level of the SMA and celiac, you really want to go up in the distal descending thoracic aorta. So now we use these terms of infraceliac or low supraceliac or high supraceliac to describe how high into the distal thoracic aorta we want to extend. Now, just completing a trial in the U.S. is a branch that allows fixation to just above the level of the celiac artery. It's called a P branch. It's a pivot branch. It's designed to be an off-the-shelf device with a big scallop here for the celiac, fenestration for the superior mesenteric artery, that's stented, and then pivot fenestrations for the renal arteries. And the way this works is, this is what it looks like. But and these branches can pivot, so you don't have to be exactly on target to make it work. But the way it was designed is they figured out kind of where most people had their branches, and they said, well, we'll start with the superior mesenteric artery, and then we'll make a scallop that's big enough to accommodate most celiac arteries, and then we figured that we could get the renal arteries if we put these pivots about here, and they had the ability to give us a little wiggle room up and down. So it's a little fudge factor built in. But this is an off-the-shelf device. It's kind of innovation that's going on currently, and we may see this in the U.S. market in the next few years. But just to kind of show you how this works, you can get through these previously wired fenestrations. You can put a sheath in there, get the sheath to right outside the fenestration, and then put a curved catheter out and direct that into the renal artery. And that's how you can subsequently get a sheath in and deliver the stent. Now, this is another device that's off the shelf. I showed you this one a little bit earlier. This is called a T branch, or thoracic branch. It's got 4 branches. It's 32 millimeters at the top, 24 at the bottom. And it just comes in this one configuration. But by putting these above the level of these branch vessels and extending down with covered stents, you can kind of make up the difference for where you're off left or right by being able to direct through the branches. T-branch is not available in the United States. There's about 9 or 10 centers that have access to it. But there's been 5,000 implants worldwide. And the thing that now limits the ability of the few centers that have access to this is the ability of the company to make them fast enough. They take a lot of handwork, and they just can't meet the demand. So these devices are actually pretty mature, and I think you're going to see stuff like this. Now, there's other innovations that have been introduced to the market, different ways to fix the graft in place, putting little screws or anchors in place from the inside, kind of like putting stitches on the inside of the vessel. These are Endofixation screws. And some of the things that we are getting on the market now in the U.S. are branch grafts. So it used to be that our grafts could only go down to the common iliac arteries, and if there was an aneurysm of the iliac artery, we'd have to extend to the external and shut down the internal, embolize it or close that off. But now we have branch devices, that can go from the common iliac to the external iliac and branches into the internal, preserving the blood flow to internal iliacs. Now that's kind of important for some patients just for functional basis because they can get thigh or buttock claudication if you shut off their internal iliac arteries. But also patients who have aneurysm disease, who have progression of disease, and they may need a more proximal repair. If they have both their abdominal aorta and their thoracic aorta covered, we know that if they haven't preserved the internal iliacs, then they're at higher risk for spinal cord ischemia. So it actually has a variety of different advantages. And then there are devices that go into places where we haven't typically gone before, branched devices that can go into the thoracic aorta or arch. And this is an example of an arch branch device that has, this is kind of looking at it from the ascending aorta end. You can see these branches. This is looking from the other side. But branches that are accessed, branch grafts are put in there to implant something directly into the arch. So just to kind of pause there, there's been an evolution of technique and devices. Endovascular is used way more than open in current practice of aortic aneurysm repair, and really we're looking at future technologies that will make the entire aorta potentially amenable to endovascular or hybrid treatments. So what kinds of treatments or what kinds of diseases are we talking about? Well, if we talk about the thoracic aorta, we're talking about aneurysm, but we're also talking about acute aortic syndromes, including dissection. And we do a lot at UC Davis with blunt aortic injury. We've talked about that in the past. Acute aortic syndromes include a spectrum of problems from a penetrating aortic ulcer to intramural hematoma to dissection where there's separation of the intima and media from the adventitia. Aortic dissections, you'll be asked to know this for an AB site perhaps, certainly for a V site. Using the standard classification, there's two kinds, the A and B. A involves the ascending aorta and the arch, that's easy, right? A. And the B involves the descending aorta, so that's pretty easy. So A and B. And it turns out if there's a problem in the ascending aorta, that's really an emergency, and these patients are at risk for fatal complications quickly, and they typically get operated on very quickly to prevent death from rupture, coronary malperfusion, aortic insufficiency, or other badness with the heart. Recent case, Thursday night, Friday morning, UC Davis, 45-year-old man comes in. He'd had chest and back pain. He went to a hospital in Roseville. His blood pressure was out of control, and they were able to figure out that when he had progressive symptoms of right lower extremity pain, numbness, and weakness, that he had a problem with ischemia in his limb. He had a CT scan. Here's that slice through the level of the chest. You can see the ascending aorta anteriorly, the descending aorta here, and you can see that there's actually a little abnormality here, and that's the dissection with the true lumen outlined and the false lumen next to it. True lumen is what used to be the real lumen, still is one of the two. This is a maximum intensity projection reconstruction of the arch, and you can see that the dissection flap starts right here, just distal to the left subclavian artery. Okay, this is a very typical entry point for a tear in the intima, creating a dissection. And this is down at the level of the abdomen. You can see the cava on screen left, and then the aorta next to the cava. And you might think that the aorta looks abnormal. You'd say, which is the true lumen, which is the false lumen? Usually the true lumen is the smaller of the two. And if you go down a little bit farther, this is the iliac arteries, the right and left common iliac arteries. One has contrast, one doesn't. The one that does have contrast has a dissection flap in it. And that's the small one is the true lumen. But the reason he had an ischemic limb and couldn't move his foot is he didn't have blood flow to the limb. So this is a different kind of reconstruction. This is one where we take the center line of the aorta and make it our reference. And so this is what we call a straight and center line curved planar reconstruction. This is the aorta. So you can see that there's a nice big lumen, but that's all false lumen. The true lumen is obliterated. And because of that, you can see in the 3D that there's a segment of this common iliac artery that has no flow at all. So that was his presentation. The way we took care of this wasn't to do a femoral bypass, which might be an option, but to do an endograft, to put a stent into the chest and open up the true lumen. And once we did that, we expanded the true lumen in the abdominal aorta. And you can see there's a septum that goes through from the proximal abdominal aorta down into the iliac, but he's got good flow in both lumens, and that has managed that problem in the short term. Graft is in place, and on the 3D, on the post-op CT scan, you can still see that there's a septum there. This is the cross-sectional view of the patient after treatment, and you can see in the chest, the stent is in place. In the abdomen, you see the 2 lumens still persist, but if you compare the pre to post, you can see that there's a lot of flow lumen now available in both those channels. Now there's some other things coming down the pike. A graft that has a covered stent in the proximal portion, here covering the subclavian, but getting seal here, covering that entry point tear, and then covering providing a covered stent through the proximal part of that true lumen. But beyond that, a series of bare stents that cover the visceral segment. So the stent doesn't have a graft that covers the visceral vessels. This has been called a petticoat endograft because it has this flared segment below with these framing stents. Now, we do a lot of trauma here. We talked about this before at Grand Rounds, but the blunt aortic injuries, one of the things that we've learned over time is that the minor injuries don't necessarily need to be treated. They don't have the same malignant potential as the major aortic disruptions. If you're bleeding into your chest, it's usually bad. It doesn't take a genius to figure out the patient in shock with hemothorax. With an aortic disruption, needs to be treated right away. But a lot of these grade 1 intimal tears and even intramural hematomas certainly don't need to be treated, and they have a pretty benign natural history. Now, aneurysms that involve the thoracic aorta and extend to the abdomen are called thoracoabdominal aortic aneurysms, and there's a number of different classifications. But the most commonly used are these, where we look at the extent in the chest, the extent in the abdomen, and categorize them. The most extensive would be the type 2 or extent 2 that involves the entirety of the aorta from the subclavian to the aortic bifurcation. So these, to be treated, really need the entire aorta to be stented. So summary here, you should know a little bit about aortic disease. You should know that dissection is different from aneurysm. You should know that acute aortic syndromes may include things like intramural hematoma and dissection. And that you're looking not only at the significance of the dissection itself and the risk for rupture, but also how it might affect perfusion of any of the vessels, the visceral or limb vessels. So one of the things that there's a major concern when we do extensive aortic repair or reconstruction is the risk of devascularizing the spinal cord. That causes pesky paraplegia, and most patients don't like that. The risk of paraplegia with complex aortic repair has been variably reported. Some of the centers have gotten that down into the single-digit numbers. Some of the reports have in excess of 20% paraplegia rates. Some of the techniques that have been used with endovascular repair is to stage the repair. You can put the thoracic component in. You can put graft from the subclavian to the celiac artery. Let that one be there for a period of time, come back, do the rest. You want to preserve the subclavian and the internal iliac arteries because those provide blood flow to the spinal cord. CSF drainage improves perfusion pressure, and short operative times make a difference because it turns out that longer operative times tend to block up the iliac arteries with these big sheaths. And the patients can be monitored with motor and sensory evoked potentials. If they're monitored and there's changes that are seen, that gives the opportunity to do a variety of different maneuvers. Increase the blood pressure, increase the amount of CSF that's being drained, or even stage the procedure. Put a graft in that has branches, but don't plug all the branches. Keep the aneurysm perfused while the patient recovers, and then come back and bridge those stents. So lots of things that can be done. What kind of results are being reported? Well, at the Society for Vascular Surgery Vascular Annual Meeting in 2016, Dr. Oderich presented the data from the Mayo Clinic, and that was published this year in the Journal of Vascular Surgery. And just using the manufactured devices, not physician modified, but things that were branch graft, custom manufactured, fenestrated and branched endografts that were treating at least into the distal part of the descending thoracic aorta, if not the entirety. 127 patients, technical success in all but one, no 30-day or in-hospital deaths, dialysis, ruptures, or conversions to open repair. 2 patients out of the 127 had paraplegia, 1 incomplete, and 96% 1-year survival. I mean, so these are really impressive numbers if you consider the complexity of the problem. And these may be patients who had previous operative repair, who then get treatment of the degenerated segment beyond the grafted artery, grafted aortic segment. It may be patients who have thoracic and abdominal aortic disease primarily. Or it may be patients who have disease involving both the ascending and arch and the remainder of the aorta. Very complex mix of cases, but here 96% 1-year survival. These are the curves. And freedom from reintervention, 86% at 1 year. And patency of the branches, the celiac, SMA, and renal, of 96%. So we're really looking at a completely different and more mature set of options than existed even 5 years ago. Well, how do you implement a program? Well, first of all, you have to have a surgical team. And a surgical team needs to have people who are familiar with both open and endovascular approaches, and not just the basic endovascular approaches, but how to handle potential technical challenges. You have to have an operating room team that includes imaging people, OR people, anesthesiologists who are familiar with these kinds of cases, can manage the CSF drains. It may require neurointerventionalists who can put in a CSF drain in patients who are difficult to put a spinal drain in. And then it requires ICU care afterwards, where people understand that the paraparesis can develop not as the initial presentation after they come out of the operating room, but even hours or a day later. You have to have the right facilities, and one of the facility requirements is the right kind of imaging. So I told you that Dr. Greenberg died from a malignancy that was thought to be radiation-induced. These cases used to take a ton of radiation, but modern X-ray units have a lot of things that they can incorporate into the system to reduce the X-ray dose. And so now, what I was seeing in Mayo Clinic using their new systems is they could do a thoracoabdominal type 2, extent 2 aneurysm with less radiation dose than we typically do for an abdominal aortogram and runoff. It's really quite impressive. But it's technology that didn't exist 5 and 10 years ago. You have to have sufficient volume to make it happen. So if you want to implement an aortic program, you have to have a door that's open to aortic patients. So at USC in Los Angeles, they wanted to build a comprehensive aortic program. They had vascular surgeons and cardiothoracic surgeons working together. First thing they did is they took the control of the referrals out of their transfer center and put it in the hands of the doctors. And they got all the referrals in Southern California because they said yes faster than Cedars or UCLA could. They went from 0 to 200 in 2 years with new transfers. And more than 50% of the patients who were referred to them had some type of procedure at some point. There are some regulatory issues and some training issues, and I'll talk a little bit about those. The FDA approves devices for marketing and use in the United States for specific uses. And if you use it off-label, that's okay. You can do that. That's the practice of medicine. But if you modify the device, if you start to sew things onto it or make holes in it, that can be interpreted as creating a new investigational device. And the FDA has said that that requires some additional oversight. The FDA is concerned that if people are doing a lot of device modifications, that they really won't have data about the short and long-term outcomes, and there may be incorrect conclusions drawn about safety and effectiveness of these techniques. They're also concerned about the consent issues, that patients might not recognize that this is not an FDA-approved device and it might be a little bit beyond the typical practice of medicine. What many centers have done with this is develop their own investigational device exemption application, and they have a protocol for modifying endografts under that IDE, which is significantly, well, very similar to the manufacturer-sponsored IDEs. Patients are enrolled. You have to define kind of who you're going to treat, how you're going to follow them, how the endografts will be modified, and then identify the risks and risk mitigation strategies. Essentially it becomes a clinical trial. So there is a mechanism to get the FDA to allow you to do this. You can become your own manufacturer, but it's under an IDE. The other thing is you want to follow up the results. And there are registries now, including the Society for Vascular Surgery's Vascular Quality Initiative, VQI, that looks at outcomes. And this is actually a tool that's being used to gather data for a lot of interventions that may be low frequency at one particular site. but gathering national data from multiple sites to look at the outcomes. And for example, there's an ongoing project that we're involved in with dissections, treatment of dissections with endografts, with follow-up through the VQI. Excuse me. I talked to you about the fenestrated endograft. The Zenith fenestrated endograft is the one that we have a couple of holes in the scallop. Well, that actually changes the complexity of these cases. So when these came out, one of the things that happened is that the company had to train people to use it, and they trained over 500 people to use it. Most of them actually used the device, and the device became more frequently used over time. But interesting data, when you look at the average number of devices per year, there's a fair number that are being used by relatively low volume implanters, and a subset are being used in high volume places. Only 5% of physicians have ordered more than 20. You'd think that that would be associated with a really high complication rate, and it's not necessarily the case. What the authors did, they looked at that and they said, well, there's not many people doing this, a high number. Maybe we ought to limit this to high volume centers. But the outcomes really haven't been shown to be different. What happens is the people who are trained and who are doing this tend to self-select. And so what happens is there's kind of a sorting that goes on. The people who don't want to do the complicated stuff don't. And the centers that don't want to accommodate those kinds of patients don't. So what are the risk mitigation strategies for low frequency, high risk activities? Well, it's having the right kind of training for the physicians and the other folks on the team. Really, the planning is, I think, the key, having detailed plans. And then there are engineering solutions to reduce the workload. The devices are easier to use now than they used to be. Standardized procedure, team training, and a structured environment. And so for some of the more complicated things like these customized physician-modified endografts, you can actually plan the case based on a CT scan. You can create a written plan for how that's going to be developed and implemented in each of the parts that are going to go in. Plan it in detail, but you can also rehearse it. You can make it on the back table. And so you can practice making it to see that your model is actually going to work. Now you have to have somebody give you a $10,000 graft to do that, but that's actually not the hardest part of doing it. But here are residents and fellows at the Mayo Clinic doing a rehearsal, constructing physician-modified endografts that they subsequently would deploy into a flow model that was based on a 3D printed model of the aorta and its branches under fluoroscopy and cannulating the branches and deploying it just as they would in the actual patient. So Dr. Jerkovich asked me to bring my crystal ball, and I did. Unfortunately, it's a little bit foggy, but I will tell you that I think that there's going to be a decreased role for these physician-modified endografts going forward because commercial technology is going to be here in the foreseeable future. In the United States, that may be several years, but it's coming down the pipeline. And so the real focus becomes how do you put programs together that are ready to accommodate these. And at this point, it does mean doing physician-modified endografts, but really having the kind of center that can accommodate patients who need these procedures. The research focus is going to shift from studies of practicality and procedure safety, which have already been demonstrated, to what happens in the long term. This is really a smart thing to do in comparative effectiveness studies, and we have to use registries for multi-center data collection and looking at outcomes assessment. And it's going to be economic drivers as well as individual sites that I think define who's going to use the technology. It's unlikely that a company will say, I'm going to spend a lot of money to bring the technology to market that I can only give to 10 sites. So that's what I have. I'm happy to answer your questions. And again, thanks to the department for letting me have the opportunity to see what the Mayo Clinic does. Dr. Hundle.
The industry, clinical, academic relationships. The technology is staggered. This 3D printer used to generate a model for the simulation was staggering. Around our system, we have some of those pieces already. And the challenge for a place like this will be engaging the components so that you can get something in time to be useful.
It turns out each of the individual bricks in the wall are not that difficult to get. but it's assembling the bricks and having the right mortar. Yeah, so we really do have a lot of the things that we need to have a complex aortic program. We don't have all. We have older
I wonder
imaging.
if this is a good opportunity to break down some of the silos at UC Davis.
Victor, what do you think?
Well, I agree with you. It's sort of interesting. I know that one of the reasons why when we started doing complex aortic surgery over at Kaiser when I was here is collaboration that I had with industry. See, I think one of the problems is that at the university we're like Dr. Sorry for the internet.
On the AU.
And we're sort of restricted in the amount of interaction that we have with industry. I think that's wrong. I mean, we should be able to accommodate them and be able to engage with them and cooperate with them to be able to bring this technology and this type of therapy to patients. I wonder if you could comment on what a learning curve is for these complex endovascular reconstructions of the thoracoabdominal aorta. I remember sitting one time watching Tim Shooter take 12 hours to do one of these cases.
Mm-hmm.
And Shooter, as you know, and as you described, is one of the most experienced endovascular surgeons of branched endograft. What do you think are the obstacles to improve that?
Yeah, I was really kind of pessimistic about this actually working. I was just as sure that thoracoabdominal aortic aneurysms wouldn't be treated with endovascular techniques as I was that gallbladders wouldn't come out through a laparoscope. And it was exactly that. It was long cases, high radiation doses, complicated procedures. In my first day in the Mayo Clinic operating room, there were 2 extent 2 thoracos that were treated. And the same surgeon did 4 other cases that day. And it took a long time because he wasn't out of the hospital until 6 o'clock that night. So what I learned is that the devices are actually much more sophisticated now, lower profile for placement, the ability to manipulate them in the patient, the ability to use imaging that can fuse the data from the CT scan pre-op with the fluoroscopy image that you have, so you can get a shadow of where all the branches are on the screen while you're moving the devices around. Pre-cannulation of the branches or fenestrations, so you don't have to find them and poke around. All these things in combination have made the conduct of these cases much more efficient, much more practical, much more achievable. Now, for a high volume center, places doing a couple a week of the most complicated cases, they're going to be pretty efficient. But those, even without that level of efficiency, these cases are, I think, technically achievable by many centers, and it's because the technology has matured. So one of the things that I learned when I was away is that the technology that I expected wasn't really what I saw. It's much more mature. It's much more ready for prime time. So if there's 5,000 T branches been sold already internationally, this is clearly something that's got traction. Sir?
One of the things that some of these other countries have is socialized medicine, regionalized the care, and to do these, like what you had your experience with Mayo Clinic, they're a high volume center that is probably the equivalent of regionalized care. We don't have that really here because we have so much competition between Kaiser, UC Davis, Sutter, Stanford, San Francisco, that our regionalized care is disjointed, which may impair getting a great operation done. Sort of like if it was your family member, would you send him to the regionalized care center, or would you have him get it done at the small center?
Yeah, that's a really good question. Where the centers of excellence are vary by which calendar you're using. Because what can be the case at one time, so UCSF with Tim Shooter, busy place, really interested in developing the new technologies, but he's kind of towards the end of his career, and their volume's going down. So they really aren't the high volume place anymore. And Stanford's really good at some things, but they don't do the branch fenestrated. So I used to think that, wow, we wouldn't be able to compete in Northern California because we've got these Bay Area guys that are, the pros from Dover. But what I saw is in other large metropolitan areas, which is kind of like our region in terms of population, there's now a second and a third center doing these things and having the volume. So I think the volume exists to support several dozen sites in the U.S. that would do this kind of work. I don't think it's the community hospitals that would do it. I think if you were a Kaiser, you'd have one place in Northern California, one in Southern California. But I think that the market forces and the other forces that drive this kind of depend on, what the situation is now, who's there now, what the interests of the institutions are. I don't think we'll have be able to have a regulatory environment that defines it, and I doubt that we'll have a professional society policy document that's able to define it. It moves too fast. So some of the places one of the things that surprised me about the complexity is that people who left the Mayo Clinic Fellowship went into practice in community hospitals or into a medium-sized hospital in an urban environment, maybe affiliated with a medical school, but not a major teaching facility. And they're doing these kinds of cases. They're doing physician-modified endografts in large numbers. And so I started to get to know more people in this community and found out that really a lot's being done that it's not published. It's out there. And so people have been able to take the training that they've obtained and apply it into practice with good results. So I think that there's more going on that I was able to see before I went and participated hands-on.
Dave, one more quickie.
Yes, sir.
You mentioned the regulatory aspects of this, and when the FDA started to regulate devices, we remember that transition. They made a big deal about phase 4 post-marketing studies. And is the FDA actually driving big phase 4 studies in this area? I got the impression that with the physician-modified grafts and stuff, that the outcomes are actually being driven by the expert institutions.
Well, there are
post-marketing,
post-approval studies are being done. So we at UC Davis were a site for a post-approval study for the Fenestrated graft, for example. So we're doing data collection.
So, right, and these are not national level post-approval things. They're
but individual sites. Yeah, that's what's not well. That's not what's not well standardized. So if someone's doing physician-modified endografts without an investigational device exemption, they may or may not have prospective data collection. They may or may not have the kind of databases that allow them to report their data. And they may choose to do it that way so that they're not being seen as doing research and avoiding some administrative problems.
Do the manufacturers follow the patient outcomes?
They do not. If they're selling a device to someone that modifies and uses it, the manufacturers don't necessarily collect specific follow-up data.
Questions for Dave?
One more.
I just want to commend you for pursuing some really innovative procedures and looking forward to that. I think having Dr. Rodriguez here, who's a double threat, not only training in Baylor and also being able to do all the left heart bypass stuff, is really going to give us a chance at UCD of bringing this aortic program over the top. I was interested in your comments to the FDA and to my own personal experience with some of these procedures. I've got a feeling your bigger problem might be the IRB. Because if you have any kind of device, even if it's approved by the FDA, if you use that device in a way that's not used by the majority of doctors, you need to go through our IRB, and they are tough. And I'm going to say, I've got a feeling that your biggest hurdle is a strategy and engaging our own IRB in this, because I mean, it's not easy. And I've had a little bit of an uphill battle, so I wish you luck in that.
I guess expanding on Dr. Boyd's note, with some of these procedures, since they're utilized, they're FDA approved, they're utilized in Europe, and as you said in the High Volume Center, is it necessary for IRB, or can you go through the Innovative Care Committee here at UC Davis? And do we still have an Innovative Care Committee?
Yeah, so if you're doing something and collecting data on a prospective basis to look at your outcomes with a particular device, especially if you've modified the device, that could certainly fall under the IRB's role. But even more than that, you have to figure out, does the institution want to take on a potential liability risk? Because they're going to have to indemnify, the surgeons for potential medical legal issues. So even if you were all above board with, the IRB issues and the FDA issues, you still have to have institution support. So the institution has to buy in. It may or may not be considered research. And then some places do it without an IDE. And so different institutions do it different ways. And it's what's their risk tolerance. And so some say, hey, we're getting a lot of volume of procedures here. We're getting good outcomes. These are widely practiced. We don't consider it research. But that's a local call. Politics is local. So you really have to find out if the institution wants to support it. But you can't really do it without all these pieces coming into place. You have to have the access, the ICU, the beds, the OR, the imaging, and the administrative pieces.
I went through, Dr. Farmer circulated a couple years ago the guidelines, what the expectation was of the IRB, very, very clear terms. And that was just a warning.
Oh, yeah, no, I
I've been on that end.
yeah.
On the,
It's not a surprise. You have some insight about the IRB, John.
So I hear things about the IRB all the time. Been on the committee for over a decade. So we hear people, how hard it is to get protocols in. And I see very few of these protocols actually come through. So turn something in.
Yeah. No,
So instead of complaining about how difficult it is, turn one in.
No,
and see what it is.
I would have no complaint about that. The issue is you have to not only have the IRB aligned, you have to have the institution aligned. You have to have a commitment to have the kind of program. Yeah, absolutely.
If you have something in mind,
Yeah.
make an attempt.
No, I think everyone.
Possible.
Yeah, that's very true. Yeah.
Yeah, I think probably not long ago I was told by Greg Moneta that it was a dinosaur. Right after he hired Cherry Abrams, who's one of the preeminent endovascular surgeons in the country. But I cannot tell you how many times I was called to do an open repair because they couldn't do it. So for those residents, open aortic surgery is very important. Even though we don't do it as much anymore, but whenever there's a case that we do open, show up. I mean, it's a dying field, if you say, but it's still a very important part of an aortic surgery.
And we see that. I mean, we've got someone who has a complex endoleak and needs revision, and that patient could be fixed with a 4-vessel fenestration or conversion to open. And for that patient, a conversion to open because of his risk profile is going to be lower risk. So not everyone gets treated with an endovascular approach, but clearly most patients now with any kind of thoracic or abdominal aortic pathology are being treated with an endovascular approach. That part's done.
Thank you very much.